We're working as one of the early adopter sites for the evaluation of the map of medicine across Wales. And we're working, our project was to work with about 9 GP practices across Conway and Denbighshire local health boards and the Trust to roll out the map to our junior doctors and work with our GP practices in terms of referral management and getting pathways and electronic pathways into the region.
So, Mr. Sinha, orthopaedics historically has a problem with wait times, doesn't it? How are you hoping that the map is going to help you with that?
The map of medicine, I think the strength lies in initiating a communication process between the primary care physicians and not only us, I would say the musculoskeletal service, which encompasses orthopaedic surgeons and a host of other specialities, rheumatology and physiotherapy and the like. And I think what we would like to do is have a standardized, structured referral strategy and an information process by which our GPs know exactly what we want them to do prior to referring their patients to us. And this stops patient going around in circles and bouncing back between departments and bouncing back to their GPs. And if we have a structured referral strategy, patients will get a better deal, their journey will be smoother, and we hope to achieve the early adopter program wants to achieve, which is a smooth journey from point of referral to the point of treatment. And we hope to do that in 26 weeks.
So who in the teams, once this is developed and used, will be actually using the map? Right.
The point of referral, as you know, is our primary care physicians. So the journey, patient's journey starts from there. So they are our primary point of contact who would need to understand what map of medicine wants to do, and particularly in our case, the knee care pain pathway. And the information they would have is what is the point of referral, what type of safe limit of treatment they can give to their patients before they refer. And before they refer, they need to do some type of basic assessment, which includes some investigation, some assessment of their medical comorbidities before they are referred to us. And then the map of medicine also extends into the secondary care, in which we as surgeons and our junior doctors, we can use that map of medicine as well for our own education.
And the nursing staff?
And the nurses, the nurse practitioners, not only in the GP practice, but also the pre-assessment nurse practitioners in our own directorate can use that quite safely and usefully.
How important has the localisation been?
I think it's a very important part because, number one, it gives us ownership because I can say, this is ours, we've designed it. Number two, these localization includes what we want our GPs to do prior to referral. There are educational leaflets there. There are protocols that we have in our directorate that we would like our GPs and our patients to know. And in that process, both our GPs and us, we know exactly what we want and how to deal with our patients. So it's making the standardization of the whole process. Everyone knows exactly what should be done, and therefore patients get a better deal.
And does everyone react positively to that? Because sometimes with medics, don't they? They like to be individual in the way that they practice. Have you had any?
You are absolutely right. You are absolutely right. In fact, that is one of our challenges, because the concept of what we want has been agreed upon. The concept of map and medicine is everybody agrees with that. But the biggest challenge is to request our GPs to use it in clinical practice, because their argument would be, oh, will it increase my workload? I'll have to go through the pathway, and you've asked for some assessments, you've asked for some pre-referral information and investigations. Do we have time to do that? And that's what we want to convince them, that as in the present system, there are a number of inappropriate referrals. Patients are occasionally referred to multiple departments. Patients fail their pre-assessment because of very basic problems which have not been dealt with in the primary care department, and they all bounce back to their general practitioners, and that increases their workload. So I need to convince them that, in effect, if we use the map of medicine, the knee care pain pathway, then they will in fact reduce their workload.
What other ways would you like to develop the map now, Mr. Sinha, for your area in the future?
I think in the future, of course, is the secondary care where we can utilize the map of medicine as an educational tool for us and our junior doctors, because it is an online version which will be accessible in the Trust website, in the library, and I would like to develop that as an educational tool for our secondary care doctors.